Thank you very much for your ideas, your suggestions, very interesting discussion. We've seen very active group around, so thank you very much for your contribution. Carol will summarize your different points, and I'm thrilled to introduce Professor Carol Popper to you. She's an outstanding economist. She has received in 2010 a CBE for her services to social science. Carol, throughout her career, had a long interest on how to improve the delivery of public services, including healthcare. Carol's research interests include the use of market mechanisms and incentives to improve healthcare delivery. She has also done work on the impact of environment on health, just to name a few. Carol has been at Imperial since 2007. She was initially the head of our health group. She is now the Associate Dean for Faculty and Research. Her previous role have included, and I just name a few, being chair of the Economics and Social Research Council Grant Board and member of the ESRC Council. She was the advisor to the chief executive of the NHS and a member of the UK Research Assessment Panel in one of the previous rounds of the UK government assessment of the quality of UK university. She has done a lot of things. You can see it all online and in our brochure. Thank you, Carol, for your contribution.
I'm very pleased to be here in the sense that I've been going around the tables and I've really enjoyed the whole day. And also going around the tables, I've just been impressed by the set of ideas and the rate of ideas. It's always really difficult, I think, in these breakout sessions to kind of know where to start other than kind of iterating what we all know. And then, you know, I think you guys have really worked for your lunch that you already had. So I kind of wanted that what's been happening has been scrolling through, so I've been listening and watching. And I wanted to start with, I think, trying to summarize a kind of key set of issues that kind of came up everywhere. And the first was and we've heard it during the day, a general reflection of the rigidity of the system. Whichever bit of the system any of the tables were talking about, you were talking about barriers and misaligned incentives, whether they be KPIs not linking to payment systems, whether they be the kind of problems that we were hearing about this morning, about trying to get new, radical, cost-effective ideas into a system in which one payer wouldn't want to pay for them and another one had money. So the whole idea of rigidity, misalignment of incentives, and interestingly, this is not just on the supply side, but also on users. So it's basically, somebody said very nicely that there's a whole issue around expectations and attitudes. And I think a really good example is 30% of the population are obese or overweight. A large proportion of the population have diabetes. And they implicitly expect a kind of 1950s model where that is solved by somebody else. So quite a few tables were reflecting. And of course, you're worried about social expectations. If you grow up in an environment where 50% of your friends are overweight, you're not likely to judge being overweight as a problem for you at 13, 14, or 15. So there's a whole pile of social expectations, rigidities on the user side as well that I think many tables were bringing up in different ways. And we haven't heard too much about today, but it's also obviously important when you're thinking about things like disruptive innovation that's going to involve users. I think clearly the politics of systems matters. All healthcare systems have large public sector involvement compared to many other markets. And that came out in many people's thoughts and discussions. And I think somebody also reflected that we have many systems that are designed to pick up the pieces. We need a set of very complete kind of reforms. We at the moment have a system that essentially institutionalizes bad health, rewards providers for essentially treating bad health, and in some ways doesn't challenge users and consumers about having bad health. And I think a lot of those things are kind of going forward. And finally, we're doing all this in a very politicized environment in which the timescale of politicians, unless you're in Singapore and have been building this since Lee Kuan Yew in 1963, or China, the timescale of politicians is short. They're always looking for the next buck tomorrow, rather than in several years, and many of these things take a while. So I think we're all very familiar with that kind of catalogue of issues, and the tables reflected the nice divergence, the kind of almost the 360 on this. So kind of I now want to move to kind of what kind of solutions that people were talking about. And I think here there was much more mixture because people were talking about particular systems and often reflecting on solutions that were appropriate for those systems. But I think I want to again draw out kind of what I think was the sort of top line issues. The first was, and I think this is a very obvious one and it came up very much in Rebecca's talk, which is we need a empowering, in the jargon of healthcare systems, you'd call it empowering patients. We need to have a system that is designed around the needs of the users of the system. If you move into more market areas, you'd think about this as consumer focus. So we need a general kind of rethink away from, if you like, a provider, an industry focus, to a consumer focus. And I think one of the tables, interestingly, reflected that this is not necessarily at all just a problem of the healthcare system, that it's a problem that affects many, for example, middle-level FTSE companies, that they're very much around the role of the provider rather than the role of the user. And that's very much what we saw in Rebecca's talk about Apple actually focusing on what a 2-year-old might want out of, or a 2-year-old's dad might want out of their mobile phone. So the first thing I think that everyone agreed on was whether they called it consumer focus or empowering patients. Secondly, within that, we need acceptance of, and this is, I think, very important, better use of data and resources. So whilst we'll all agreed that there's masses of big data out there, that's what most of my work is about, for example, there's lots of challenges to use of this data. And there were some tables that reflected that that might be changing for the better, in that what 30-year-old and under 30-year-old actually cares about their privacy. They know that anyone can hack into anything. On the other hand, the 65-year-olds, who are mainly the users of systems, are still very unknowing about data and very fussy about how their data is being used. You can see it within the NHS already. People are opting out of the big data systems that we have on them. So there's a need to use data both by providers and involve users in using that data and using their own data and becoming aware of using those data. The third thing was that, and I think this reflects many tables, issues around strong leadership and clear vision. And I think that echoes something that's been said a lot today that underlies a lot of things. There is a need for leadership here, whether we call it governance, whether we call it leadership of the firms that are on the provider side of the market. There's a need for people to take that leadership role, and I think that's a talent that's in very much short supply, and possibly is very much in short supply in very politicized healthcare systems, where basically what leaders do is play to politics rather than actually leading their organizations. So that was one very clear message that came out, that we need to enable leadership. We need to be able to take that clear vision. And finally, I think, or two more things, and around that, there was ideas of discovery-driven adoption of innovation, that we want things like trials and things. I think I'm mixed about trials, and I think there are issues about using trials, but there's certainly an idea behind that we want experimentation, we want innovation. One size does not fit all. When all is the patient, no patient is an average. And finally, I think a very interesting idea that came out is the current system is essentially designed to pick up the pieces and in some ways has no attitude towards risk. And what quite a few tables were kind of reflecting is there's a need for risk sharing. We've heard about models of risk sharing on the provider side, that you're taking risk sharing when you're a venture capital. You're risk sharing with the producers of new ideas. So there's definitely a need for different models of funding, which essentially are about different models of risk sharing. But there's also a need for risk sharing with patients. We may be thinking about new models of care in which we expose patients possibly to more risk in order to give them incentives to take better care of their health. A nice example would be some of Singapore's, you save for your own health and you help poor people save for your own health. But in a sense, you're pushing some of that risk back onto people in the idea that that will give them incentives to look after their health better and to adopt what's being offered by the system. So I think there's a general need to look at the kind of risk models that we have, if you like, both financial risk and other risk models in this space. So I think those were really fascinating ideas that all came from the tables, and I hope that gives you kind of some flavor of the people who haven't talked in the discussion and some flavor of it. What was very much a kind of consensus, I think, set of ideas. So thank you.